right. Well, hello, everybody. Hello and welcome. My name is Bruce Robinson. I'm the Scientific Director for the DOPPS program, and thank you all so much for joining us for this autumn update meeting. This is should be an exciting week with the ASN Kidney Week just launching today, and what looks like a really interesting program starting a bit later in the week. So I do hope that folks have a chance to attend virtually a number of the meetings. And we here at the DOPPS program have had a tradition for many years of having update meetings in the spring with the ERA EDTA and in the fall just before the ASN. And so here we go today with our second virtual meeting after the spring update meeting in June. And I do so much appreciate folks who've been able to join today. We do recognize it's a very busy day for many people with the start of a workday here in the Americas and the middle of a Monday afternoon in Europe. And of course, we're butting well into the evening for those of you joining us from Asia. But we do have an international audience and international speakers really from around the world today. So really looking forward to this. Next slide, please. Oh, good. Okay, good. So thank you so much. This is just a preview for next year. Indeed, we will be at the 25th year of the DOPPS, and so we're looking forward to that so much. The prior slide had some balloons, but hidden by a screen. They're not quite yet ready to drop, but next year we'll be so pleased to celebrate our 25th year of the program. Next slide, please. And indeed, we have... Sorry, there's a bit of a delay with the slide advancement, so it's just so the speakers are aware of that. Okay. Anyway, after 25 years of the DOPPS, we're just so appreciative of all of our sponsors, and here are the current program sponsors. Thank you so very much. Next slide. We're also so appreciative of all of you who have contributed to the DOPPS program, including our country investigators, our site coordinators, site investigators, and most of all, the patients working with us. Thank you all so very much. And next slide. We're indeed now currently active in a total of 19 countries across our three major study programs, over 775 sites, and 34,000 patients enrolled. So really just a tremendous effort on the part of so many folks. Next slide, please. And indeed, we've kept up our mission has been and remains to identify variation in practice and indeed or describe variation in practice and identify optimal practices. And with this in mind, we have kept up a very robust publication program, which probably approaching another 20 publications this year with analyses done here at Arbor. And indeed, we have a number of other folks around the world who are working with our data and submitting publications actually separate from the numbers you see on this publication total slide. All right, and then Chris, on to the next slide, which is, the next slide should actually be the ASN abstracts. Okay, we do, and with our robust publication program, we do have a ton of abstracts, actually a total of 12 poster presentations as noted here quickly, and then the next slide shows that we have 3 different oral poster presentations, one each from our 3 studies, DOPPS, PDOPPS, and the CKDOPPS. And this slide after that provides an update. Yeah, the next slide will provide just the agenda, which has been sent around to folks. And indeed, we have a packed agenda today, so we'll push forward very quickly with that. We'll actually start with an overview of COVID, and then move into research presentations from our DOPPS study, event-centered dialysis, PDOPPS of peritoneal dialysis, and CKDOPS and advanced CKD. We have a total of 9 presentations, each of which we've slotted around 15 minutes of time to over the next 3 hours. Next slide, please. So it's really important to us to make this session as interactive as possible. It just keeps keeping the conversation rich. So we do ask participants to please submit questions to us. You actually don't have the chance as a participant to speak by audio, but you can use the Q&A question and answer function. And so please do submit your questions, and we'll triage those among our presenters and be sure to answer either online in response or by audio. So thank you very much. And next slide, please. All right. With that, we're going to launch into the core content of the 3-hour session, and we're going to start with an update on COVID-19. And I've asked 2 of our investigators that work closely with us, Rita Suri, who's a country investigator for the DOPPS based at McGill University in Montreal, and Laura Labriola, who works closely with us at the Catholic University of Louvain in Brussels. And I asked the 2 of them together actually to provide an update on COVID-19. Next slide, please. Before asking them to speak, I was just going to provide a brief overview of where the DOPPS stands with respect to COVID. We are just starting to collect have available clinical data, as the patient-level data from the clinical records. This would be diagnosis, testing, outcomes. And indeed, our U.S. DOPPS Practice Monitor, which we update twice a year with the latest in practice trends, this will be updated within about 2 weeks. And we will present data with respect to any potential changes in practice that we are seeing on the hemodialysis side with respect to COVID. Those will be some of the first data available to my understanding, actually, in this regard. We also have a survey that we distributed to our DOPPS sites earlier this year in the second quarter, and Laura will present some early results from this. We also have a poster on that as well. And then secondly, we've actually expanded that survey and collaborated. We're actually quite excited to announce a collaboration with the International Society of Nephrology to distribute a variation on that survey, actually to countries around the globe. So it should be, we imagine, tens of, perhaps 50 or more countries that will actually, where we'll have dialysis medical directors responding to the survey. This will be distributed very shortly, related to in-center hemodialysis as well as PD, and including not only high-income but also middle and lower-income countries. So we do look forward to those data as well. And next slide, please. Okay, and actually then, so in terms of the COVID update that Laura and Rita are going to provide, Rita will speak first to general burden and outcomes related to COVID. Both Rita and Laura will provide some perspective from their own specific countries, and Laura will provide results on early survey results that we have, and Rita will end up with some closing thoughts on this. We have about 20 minutes for this particular presentation. With that, next slide, please, and I'll pass the microphone on to Rita. Thank you.
Thank you, Bruce. I just want to take the time to thank Bruce and the DOPPS team for inviting me to present on this topic, which has unfortunately become very important over the last year. So the first slide here talks about the generalities of COVID burden in the entire world, just to put it into context of our participating countries in DOPPS. And on the left, you can see the European countries. In the middle are the North and South American countries. And then on the right, you'll see the Middle East and Asian countries. And you can see that the burden of COVID varies greatly among our DOPPS countries in the world, with Europe and the Americas having higher case burden than the Asian countries. And everybody knows this from the news. The next slide shows the burden of COVID in the renal replacement therapy population in the DOPPS. And you can see it very much mirrors the prevalence excuse me one moment. Yeah, sorry. It very much mirrors the burden of COVID in the general population. So again, the European and the American countries having more COVID burden than the Asian countries. Next slide, please. I don't think that the proper slide deck is actually loaded. Anyway, we will proceed with what we have here. The seroprevalence among dialysis patients was also looked at in a couple of studies. So in China, they screened 1,500 or roughly there, so hemodialysis patients with antibody testing and found a prevalence rate that was much higher of around 3%. And only 0.3% were actually diagnosed by RT-PCR in terms of cases, of which 50% were symptomatic. In the U.S., they also tested several thousand patients with respect to seroprevalence and actually found a seroprevalence of around 8%. And this is very much different between northeast and western parts of the country. As well, the risk factors for seroprevalence are Black and Hispanic populations, and if you lived in a very high density city. Next slide. The COVID by dialysis modality. COVID cases are obviously much more common in in-center patients than in home patients, but we were actually a little surprised as to how much different it was. This is not actual quantitative data, but basically based on personal communications with the investigators. Urgent study is needed to actually document how much the infection is more prevalent in in-center versus home hemo and PD patients. Next study. Next slide. The case fatality ratio among dialysis patients. So this is also very sobering and surprising that the case fatality ratio is 10 to 30% among dialysis patients that have been diagnosed by targeted testing. Now, if you look at the actual case fatality ratio by seroprevalence, it'll obviously be a lot lower because the denominator here is basically cases and not those who are also seroprevalent. And these numbers come from published reports as well as personal communications, and the EREDTA recently published a 20% mortality rate at 28 days. And this is what we're finding across the country. So this doesn't seem to vary very much. In other words, the rate of death over the number of diagnosed cases is consistent at around 20%. But if you look at the rate of death among all dialysis patients, of course, it varies 100-fold according to the difference in prevalence across the regions. So regions who have a very low prevalence of COVID will have very low death rates as well. Next slide, please. So in Canada, this is just a little map of our country, and you can see it's divided into several provinces, of which the two most populated I've highlighted there are Ontario and Quebec, and unfortunately these were the two provinces that were also the most heavily affected with COVID. You can see that, in fact, our first community transmission only occurred on March 7th, so a little bit later than other countries. And thereafter, all provinces which have their own provincial jurisdictions and have say over their own public health, they all kind of came up with a state of emergency declaration. And I think that one of the reasons why Canada was relatively spared during the first wave, why Canada was relatively spared during the first wave was that there was a cohesive and relatively uniform response of the governments at all local, provincial, and federal levels. And in addition to that, and not to be underestimated, is the importance of buy-in from the general population. And you can see that, like other countries in the world, we are now suffering from a second wave and trying to get a hold of that. In terms of dialysis in the Canadian population, so again, that mirrors what we saw in the rest of Canada, in that Quebec and Ontario had the greatest number of cases. And the number of cases is, again, similar to what other countries around the world had, so around 2 to 3% and around 20% death rate. It's important to note that in Canada, as in probably the U.S., 60% of the cases and deaths were in dialysis patients residing in long-term care facilities, and this is an unfortunate problem that we have here in Ontario and Quebec, and the governments are trying to get a hold of this. Fortunately for us, there were few outbreaks in the dialysis units themselves, so very little person-to-person transmission. A couple of units did have that in Ontario, but quickly implemented very rigorous screening protocols at the door for all dialysis patients, plexiglass for our very small crowded units where social distancing was not possible, and we have a very low threshold for testing and isolation. I think these measures really kept COVID from spreading within the dialysis unit despite the high burden of long-term care dialysis patients having it. We also cohorted patients who were in long-term care facilities together to protect the rest of the population. In addition, I think one of the major things that helped our country was that we are a small country, but we're a very cohesive country of nephrologists and kidney specialists and dietitians, nutritionists, social workers, and patient partners that engage in research and clinical care together. And this network was mobilized very rapidly through the Canadian Society of Nephrology to produce recommendations, which were then available on the CSN website and published later on, and I think this helped with our curbing of the disease. So with that, I will turn it back to Laura.
Good afternoon. As you know, Belgium was severely hit by the virus. However, we have to say that the high mortality rates in the general population includes, in contrast to most countries, not only confirmed but also suspected but not tested cases who were common in nursing homes in all the country. In contrast, all the figures that you see here in the table concerning incidence and mortality rates in dialysis patients include only positive and confirmed cases. Continuity of care was maintained in all Belgian facilities without regional dedicated COVID units as done in some Asiatic countries. And the detection and isolation policies were aggressive and included the mandatory use of surgical masks for both staff and patients very early in the history of the pandemic, in some units already in March. In some units also the morning sessions have been shortened to avoid the crossing of morning and afternoon patients in the corridors of the facility. Next, please. This is your experience concerning the prospective monthly serologic assessment of corona infections in our unit over 3 months. Almost all diagnosis positive PCR patients seroconverted, even 2 asymptomatic women who were diagnosed by systematic PCR screening. In contrast to cross-sectional studies, none of the 88 patients who were negative on screening PCR seroconverted during studies, suggesting that our infection control protocol was effective. No patient became seronegative during follow-up, as you see here in both figures. However, you can see very well that specific IgG levels decreased with a linear trend by more than 60% in all of them at the end of the study. Next, please. Now I will show you the early results of the International DOPPS survey assessing the impact of COVID-19 on dialysis practice. Next, please. Here you can see that in Europe and the US, more than 60% of the units included at least 1 infected patient. In contrast, you can see here on the left that none of the 42 included Chinese facilities had any positive case. But we have to remind that only 3 Chinese cities are included in DOPPS China, and these are Beijing, Shanghai, and Guangzhou. All of them are very far away from the epicenter of the pandemic in central China. Concerning infected staff, here at the right, you can see that the figure B mirrors more or less the figure A, with European facilities being globally, we can say, more hit than American ones, at least at that moment. PCR testing, next please. PCR testing was widely available only in China, whereas half of the included American and European facilities had some problems with that. Universal antibody testing was available only in 1/4 of the European facilities and in none of the included American units. Next, please. Contact tracing has been extensive in Chinese units, moderate in Europe's units, and quite more limited in the American units, and currently remains also insufficient in countries with a high number of cases. Next, please. Unfortunately, shortage of material researchers was far to be uncommon, and the reported proportions are important, as you see here, and they were more or less the same in the 3 geographic regions. Another, the last one, please. Yes. Another resource limitation were staff absences, as you can see here. And a significant proportion of nurse managers had to call outside staff for personal replacements. Next, please. Switching COVID patients from hemodialysis to hemodiafiltration with the aim to reduce hypercoagulability risk was not very frequent, as you see here in this slide on the left. And the same thing we can say for the switching to middle cutoff membranes for dialysis. The next, please. Transportation to and from dialysis units was in general more problematic than usually, especially as you can see on the left in China and Europe. And the big problem were urgent vascular access interventions, which have been clearly more difficult to obtain, and we can say even much more challenging in 1/4 of the facilities in the 3 geographic areas. Next slide, please. Skipped sessions of patients in general were exceptional or relatively exceptional in the European units participating at the survey, but were a concern in more than 1/3 of the US unit that participated at the survey. Next slide, please. Accordingly, a substantial proportion of the American units were more likely to use pharmacologic interventions as the prescription of potassium binders, as you can see here, 43%, so more than usually. And not only American units, but also Chinese units prescribed much more looped diuretics and especially oral bicarbonate than usually. Next, please. When this survey was made, a proportion of medical directors in Europe said that they would be more in favor to encouraging kidney transplantation after the lockdown. And in the same perspective, in the 3 geographic regions here on the right, the medical directors said that home dialysis would be sure or certainly more likely to be recommended in the near future. Next, please. So although these yearly results highlight very different realities in the 3 geographic areas, we can say that pandemic has led to a number of changes in dialysis practices overall. Logistic and resource limitations were quite common, as shortage of staff and the difficulty of obtaining vascular access procedures. The upcoming results of the combined survey expanded to low-income countries will help the kidney community share experiences in order to adapt policies and recommendations to this new global critical situation. Thank you very much.
Okay. Unter dieser Festnetznummer, ja? Ja, super, perfekt.
Thank you, Laura. Next slide, please. So in summary, what we can say from this section is that the burden worldwide for dialysis patients with COVID was relatively high, with 3 to 4% cumulative median incidence and a case fatality ratio of 10 to 30%, but this prevalence and incidence really varied with the prevalence and incidence of COVID within the community, and varied almost 100-fold between countries of Asia, the Americas, and Europe. The cases were obviously more common in in-center dialysis than in home hemo and in PD patients. Next slide, please. It raises the question of how we can best protect dialysis patients. So one of the things I was thinking about, and others have discussed with us, is how can we better diagnose our patients. Right now, we're testing only symptomatic and exposed patients. And the testing is not very comfortable from what patients have said. It's very unpleasant to have the nasopharyngeal swab done, especially to have it repeatedly several times over the week or the month. And so we do need future rapid testing of saliva tests and so forth, but the diagnostic accuracy needs to be confirmed. With respect to the antibody responses, largely unknown in dialysis patients. For example, if patients are infected, do they become immune? Does it, just like the general population, do they mount an antibody response? How long do those antibodies last? This poses a lot of questions with respect to vaccination as well. When we vaccinate our patients, when the vaccine is finally available, is it going to work? In terms of a near-term concern, obviously the second wave is here, and the winter wave flu season is coming. I know that in Australia, they actually saw almost 0 cases of flu during the summer normal flu season that they usually have. It's their winter, our summer. And that was actually reassuring that they had very low numbers of flu cases while the COVID second wave was ongoing. I think that the major issue is to try to protect patients in long-term care facilities, as well as to look at our underprivileged Black and Hispanic populations in the U.S. and other underprivileged populations in other countries. And then finally, with respect to dialysis units, asking them about their burden of how difficult they find it to keep ongoing implementing these infection control measures, which aren't easy on staff or patients. Next slide, please. Finally, we can ask whether home dialysis use will increase. So this might be a positive, and certainly in the U.S., more people are considering home dialysis. Here in Canada, more people are asking about home dialysis as well. We had to shut down our home dialysis program during the first wave, but certainly this is not going to be done during the second wave. And in fact, most centers are actually going to push increasing home PD and home hemo. Will the initial enthusiasm continue? It seems to be waning a bit, but I'm hoping that it's going to keep going. And telemedicine has been a big win for many centers, especially throughout the U.S., with respect to trying to treat our dialysis patients remotely. Next slide, please. Finally, the other positive that we can take from this is that many countries have witnessed new methods of collaboration in a very rapid, efficient, and cohesive manner so that we can optimize patient care. So examples of what the different countries have done there in terms of Canada, the US, and the UK. And this is really a testament to the human spirit and the ability of people to cooperate together and be able to come up with plans that actually protect the population in a very effective way. I will end it there.
Rita, Laura, thank you so much. That was great. Perfect. Just a couple very quick comments. First of all, as Laura noted with her data from Belgium that I think are very soon to be published, it does appear, of course, that there is waning immunity over some time. So those data that Laura has are actually very interesting in this regard. It does seem that seroprevalence is going to be in the range, as noted by you, Rita, perhaps 10 to even up to 30% in countries or regions where COVID is quite common. And with the second wave, of course, we'll see yet more of this. So a lot to learn in that regard. It's also interesting, Rita, to hear that you anticipate, if anything, still greater move towards home dialysis, and that would be very welcome change. And certainly I think many patients would really appreciate this given what COVID has, how difficult the idea of coming in for in-center dialysis has been for patients. Just before we end up, I was just curious for Rita and for both of you, with the second wave really upon us in many parts of the world, but certainly in Europe, the U.S., and as you noted in your slide, Rita, in Canada as well. Just basically, what's the mood like there, or in dialysis units? Are patients and/or staff quite weary and concerned as they're moving into the winter, or feeling a bit more optimistic?
I think it's a bit of both, Bruce. People are a little bit more optimistic and less scared than the last time because they know the procedures, and so they're more comfortable with them. On the other hand, there is this kind of sense of dread and decreased morale and fatigue, really, as to how long is this going to continue. So I think it's a bit of both, and I think that reflects what's going on in the general population as well.
Yes, in Belgium, I can say that the patients and the personnel are not so optimistic, and they're scared. Yes, it's not easy. Of course, we have the same protocol than before, and we want to make a systematic PCR in all the patients, perhaps once per month. We don't know yet. But I think that there is no optimism. People are scared. Yes.
Yeah.
Well,
of course,
it would be interesting to have.
Go ahead.
Sorry, you mentioned the routine PCR testing once a month. It would be interesting to have some more formal data from all the countries with respect to that, because I know in Quebec we have tested in several of our units routinely, and we found no cases additionally with respect to that. So it hasn't really led to anything.
You found no additional cases in that regard. Of course, though, perhaps that's in a sense, a good thing as it were. But also, of course, if the burden is low enough, then if you do survey and you identify 1 to 2 patients, you can truly act on that and perhaps make a difference, of course, as you know. Particularly with the movement towards the rapid antigen testing and rapid antigen tests, which do need evaluation in terms of test characteristics, but even so. I was struck in the general population in China. There was a city, the name of which I'm not quite remembering, but where they had 10 cases of COVID recently, and their plan was to do rapid antigen testing literally on millions of people to assure that they tamp down any potential for spread. So I do think that there's a role for rapid antigen tests, even if test characteristics aren't perfect, but they are able to do pretty well, I think, at determining when folks are highly infectious. Well, it's so interesting as well because, and again, as you all noted, dialysis patients and staff can do everything possible to protect themselves, and people are really just doing heroic work, patients and staff. But we're just so beholden to what's going on in the broader community. So, and of course, it's the dialysis community that is among the highest risk, and is noted in particular folks who live in skilled nursing homes, folks in minority communities, et cetera. So, unfortunately, we have a long way to go still till this situation is behind us. Thank you again, Laura and Rita. Thank you very, very much. We're going to move on now to the DOPPS in-center hemodialysis study.